everyone, my name is Jessie Signorelli and I am a clinical pharmacist at Mass General Hospital with the leukemia team. And today I'm going to be going over the use of Venetoclax in patients with newly diagnosed AML and focusing more on practical considerations for pharmacists. This will be a 30-minute presentation and I have nothing to disclose. In this presentation, I'm going to be going over the use of Venetoclax in patients that are not candidates for intensive induction chemotherapy. So these will be patients that are age 75 years or older or have comorbidities that would preclude them from being able to get intensive chemotherapy. This indication was approved in November of 2018 based off of some phase 1B data. We now have phase 3 data that was just published in the New England Journal of Medicine back in August, but that data has not made it to the labeling yet, so we're going to be focusing on the phase 1B data in today's presentation. If you do have questions at the end of the presentation, I'd encourage you to visit the website at the bottom of this slide, and there's some resources there where you'll be able to get your questions answered. Some of the risks of Venetoclax include tumor lysis syndrome, neutropenia, and infection. Of note, Venetoclax was studied in patients with multiple myeloma, and there was an increased mortality in that study, so Venetoclax is not used in those patients. The beginning of this presentation, I'll go over the clinical safety and efficacy data of Venetoclax in the phase 1B trials, and then we'll get to the more fun part, which is the practical considerations, and that will include differences in dosing with CLL and AML, tumor lysis syndrome, prophylaxis strategies, as well as dose modifications of Venetoclax for drug interactions and for adverse events. Diving right into the clinical efficacy, Venetoclax was studied in 2 open-label, non-randomized trials in patients newly diagnosed with AML. So these were patients that were greater than 60 years old or older, and they were not eligible for standard induction chemotherapy. Patients with intermediate or poor risk cytogenetics were excluded. On the left here was the trial with Venetoclax with hypomethylating agents, Azocitadine and Decitabine. And on the right here was Venetoclax in combination with low-dose cytarabine. One of the key differences in the trial was that in the trial with cytarabine, patients were still allowed in the trial if they did receive previous treatment with hypomethylating agents for the treatment of MDS, where those patients were excluded in the trial looking at Venetoclax with hypomethylating agents. In both of these trials, patients did not start treatment until the white count was less than 25,000 to decrease the risk of TLS, and treatment with Hydrea was allowed prior to enrollment. The median age in these trials was 75 to 76 years old, and patients primarily had a performance status of an ECOG of 0 to 1, and patients with secondary AML were included in both of the studies. The mutations that were looked at was TP53, IDH1 and 2, FLT3, and NPM1. And then you'll see again, no good risk cytogenetics in these patients. And then at the bottom, you'll see some of the baseline comorbidities that were considered to have precluded patients from being able to receive standard induction with 7 and 3. As far as response rates, this slide is color-coded. So with Azocitadine, it's the light purple, Decitabine is that middle purple, and then low-dose cytarabine is the darker purple. So starting in the top left of the slide, you'll see the complete response rates. With Azocitadine, the complete response rate was around 40%, around 50% with Decitabine, and then around the complete response rate was around 20% with low-dose cytarabine. It's kind of hard to say what mutations did the best in the phase 1B data just because the numbers are so small. It did appear that patients with NPM1 and IDH1 and 2 did well, but again, the numbers are very small. Median follow-up was around 6 months with low-dose cytarabine and 11 to 15 months with venetoclax and decitabine and azocitadine, respectively. The median time to first complete response was 1 month for azocitadine and low-dose cytarabine, and it was around 2 months with decitabine. This is a lot shorter time to first response than what we see with hypomethylating agents alone. With hypomethylating agents alone, we can see time to first CR of around 4 months. And as you can see, it's much shorter now with the addition of venetoclax. The median observed time in remission was around 6 months with low-dose cytarabine and around 7 months with azocitadine and decitabine. Around 50% of patients did become red blood cell and platelet transfusion independent, which, as we know, is important for our patients because if patients aren't being shuttled to clinic frequently to get transfusions, they can potentially have an increased quality of life. Despite the decrease in transfusions, we did see some hematologic toxicities. So first I'll go over the safety profile with azocitadine and decitabine, and then the following slide, I'll show the safety data with low-dose cytarabine. I want to draw your attention to the box on the left-hand side here, and really pointing out that over half the patients had to have dose interruptions due to adverse events. So as pharmacists, when we see that, we're thinking about, okay, what were those adverse events that we needed to interrupt therapy, and what does that mean for increased monitoring? The toxicities that were seen the most was hematologic and GI toxicities. For hematologic, about 50% of patients had grade 3 neutropenia and thrombocytopenia. So that was the most common reason for dose interruption. Gastrointestinal side effects were common, but as you'll see here, there was very rare grade 3 or more GI side effects. They were really limited to grade 1 and 2. Now, the columns between azocitadine and decitabine aren't meant to be comparative. The trial wasn't set up to compare the two arms, and the numbers are very small. But it does appear that there may have been a little bit more GI toxicity in the azocitadine arm, which we can expect because, as we know, azocitadine is considered to be moderately emetogenic per our NCCN antiemetic guidelines, where decitabine is minimally emetogenic. Another thing to point out, and this goes with the rates of neutropenia, was we did see infections in these patients, pneumonia, UTI, cellulitis. So vigilant monitoring for infection will be important in considering antimicrobial prophylaxis. The safety profile with cytarabine was very similar. About half the patients had dose interruptions due to adverse events, very similar to with hypomethylating agents. The rates of hematologic and GI toxicities, again, very similar. And then we did see 2 patients have tumor lysis syndrome in the cytarabine trial, which we didn't have any in the hypomethylating trial. This was laboratory TLS, and there was no clinical signs of TLS. But again, it goes to show that we really need to employ our tumor lysis syndrome prophylaxis strategies, which we'll talk about. This is a slide to visualize the differences in dosing when in combination with hypomethylating agents versus with low-dose cytarabine. So with the first cycle and initiation, you're going to be using a ramp-up dosing schedule to decrease the risk of tumor lysis. So on day 1, it's 100 milligrams. Day 2 is 200 milligrams, and then day 3 and onward is 400 milligrams if in combination with decitabine or azocitadine, where if in combination with low-dose cytarabine, you'll have the 400 milligrams on day 3 and then increase to 600 milligrams on day 4 and afterwards. So that was the clinical safety and efficacy data, and now we can get into the more fun part of the presentation, which is kind of those more practical considerations. So we'll look at the differences in dosing between CLL and AML, tumor lysis syndrome, prophylaxis strategies, and recommended monitoring, and then looking at dose modifications for drug interactions and cytopenia management. My colleague, Matthew Lee, will be doing a symposium tomorrow looking at Venetoclax and CLL, and he'll go over this in much more detail, so I won't focus too much on Venetoclax and CLL, but I do want to point out that in CLL, Venetoclax is much more gradual ramp up. So the ramp up is over 5 weeks, where in AML, as we kind of just went over, the ramp up is over days. And we're starting at a higher dose of 100 milligrams. TLS monitoring is also a little bit more frequent in CLL than in AML. In AML, it's recommended to monitor tumor lysis syndrome labs 6 to 8 hours after each ramp-up dose. And then when you get to your target dose, it's again 6 to 8 hours to get tumor lysis syndrome labs, and then again 24 hours after reaching that target dose. For CLL, when we're looking at risk assessment for tumor lysis syndrome risk, we're looking at the lymph node size and the absolute lymphocyte count, where in our AML patients, we are looking at our patient-specific factors, specifically the white count, baseline LDH, baseline serum creatinine, and it's recommended to not start therapy in AML until the white count is less than 25,000. And you can use cytoreduction to get the white count down before starting treatment. And this is most commonly with hydroxyurea. As far as tumor lysis syndrome prophylaxis, some strategies may be similar in CLL versus AML. In AML, it's recommended that all patients be put on an anti-hyperuricemic agent prior to starting therapy. This is most commonly with allopurinol 300 milligrams daily. It's also recommended that all patients are able to maintain adequate hydration so we can really flush out their kidneys to decrease the risk of TLS. And if patients aren't able to maintain adequate hydration, IV fluids should be considered. So now we have a patient case to kind of apply what we've gone over so far. Mrs. R is a 75-year-old woman who presented to the ED after months of fatigue and bruising. She has a past medical history of hypertension and diabetes, and she is on medications for both of those. Her CBC workup reveals a white count of 30,000 with 70% blasts. And a platelet count of 24,000. Her CMP reveals a serum creatinine of 1.4 times the upper limit normal. And her bone marrow biopsy confirms the diagnosis of AML with 85% myeloblasts. She has intermediate cytogenetics, and she's positive for NPM1 mutation as well as FLT3. The patient begins treatment with Venetoclax and Azocitadine. So the question here is, are there any interventions to recommend to your healthcare provider prior to starting therapy with Venetoclax and Azocitadine? So you can have more than one answer be correct. Option 1 is yes, the white blood cell count must be less than 25,000 prior to initiation of Venetoclax. Cytoreduction prior to treatment may be required. Option 2 is yes, start an anti-hyperuricemic agent. Option 3 is yes, you must decrease the creatinine to less than 1 as Venetoclax is extremely nephrotoxic. Option 4 is yes, you must transfuse with platelets to prevent any bleeding during therapy. And 5 is no interventions are required to start treatment. So if you guessed options 1 and 2, you would be correct. Prior to starting Venetoclax, we want to make sure our white count is less than 25,000 and using hydroxyurea for cytoreduction and making sure that all patients are started on allopurinol 300 milligrams daily prior to starting therapy. Option 3 is wrong is because Venetoclax has not shown to be nephrotoxic. And option 4 is wrong because when you're initiating Venetoclax, you're not as worried about the platelet count to be able to start treatment. So now for Mrs. R, we're starting voriconazole on day 9 of cycle 1 because she's neutropenic for antifungal prophylaxis. And the question here is going to be, what dose reduction of venetoclax do we need to use when adding voriconazole onto therapy? And to answer this question, we need to know what level of CYP3A4 inhibition that voriconazole exhibits. So here you'll see a table of CYP3A4 inhibitors and inducers. Some of these agents might be in categories that you're not used to seeing them in because the FDA did just recently recategorize some of the agents here, but I'll point out the ones that we see most commonly in practice. So for strong 3A4 inhibitors, I'd say the most common that we see is voriconazole and posaconazole. For moderate CYP3A4 inhibitors, the most common that I see is aprepitant and ciprofloxacin, diltiazem, fluconazole, and isobuconazole. For PGP inhibitors, the ones I most commonly see are amiodarone and carvedilol. And then as far as strong CYP3A4 inducers, the one that I see most commonly would be St. John's wort. So that's just pointing out that it's really important to be asking these patients if they are taking any herbal supplements over the counter, because that is one that I sometimes hear patients taking. So venetoclax is a substrate of CYP3A4 and does require a dose reduction when in combination with CYP3A4 inhibitors. At the top left here, you'll see the venetoclax dosing that we've gone over previously. And then just keep in mind the tablet strength sizes for venetoclax is 10 milligrams, 50 milligrams, and 100 milligrams. So keep that in mind when you're thinking about the different dosing for ramp-up dosing, what tablet sizes you're going to use. Posaconazole has a different recommendation than other strong CYP3A4 inhibitors, and this is because there was a pharmacokinetic study that was done specifically looking at venetoclax with posaconazole. And what this study found was that venetoclax 50 milligrams and 100 milligrams was safe to use and tolerable with posaconazole. So that arrived us with a recommendation of a target dose of venetoclax 70 milligrams when in combination with posaconazole. So the ramp-up dosing, if a patient is already on posaconazole, would be 10 milligrams on day 1, 20 milligrams on day 2, 50 milligrams on day 3, and then 70 milligrams on day 4 and afterwards. If a patient is already on venetoclax at their target dose and you're adding posaconazole on, you'll just decrease your venetoclax straight to 70 milligrams. As far as with strong CYP3A4 inhibitors, you're going to be decreasing venetoclax about 75%. So the ramp up is very similar to with posaconazole, but your target dose on day 4 is going to be 100 milligrams. So think 75% of your 400 milligrams is 100. And then with moderate CYP3A4 and PGP inhibitors, you're going to be thinking about a venetoclax dose reduction of around 50%. So again, the ramp up is a little bit similar. So on day 1, 50 milligrams, day 2 is 100 milligrams. And then if in combination with a hypomethylating agent, your target dose is 200 milligrams. So think 50% of 400. And then if you're using venetoclax in combination with low-dose cytarabine, you'll be thinking about increasing on day 4 to 300 milligrams, because again, you're thinking half of that target dose of 600 milligrams. If your interacting agent is discontinued, you can resume the venetoclax, increase the venetoclax full dose back up to full dose 2 to 3 days after discontinuation of the interacting agent. So now applying this to our patient case, remember Mrs. R had voriconazole added to her venetoclax regimen for cycle 1. So only one of these can be right. So which of the following statements is true? 1, venetoclax should be reduced to 100 milligrams daily. Once voriconazole is discontinued, the previous dose can be resumed 2 to 3 days after. 2, venetoclax should be reduced to 200 milligrams daily. or 3, venetoclax should be reduced to 70 milligrams daily. So if you can remember, looking back a few slides ago at that chart, voriconazole is a strong CYP3A4 inhibitor, so we're going to recommend a 75% dose reduction. So the correct answer would be 1, venetoclax should be reduced to 100 milligrams. If you guessed number 2, you might be thinking of moderate CYP3A4 inhibitors, so that would be with isovuconazole or with fluconazole. And then if you picked option 3, that would have been right if you were using posaconazole, because remember, posaconazole has different recommendations than the rest of the CYP3A4 strong inhibitors. Another important consideration is, as we discussed earlier, over half the patients did have dose interruptions due to adverse events. So that's kind of making us think we need to really monitor the blood counts throughout treatment and interrupt our dosing for severe neutropenia. And then also thinking about what supportive care measures we can employ to decrease the risk of infection during neutropenia. So that could include antibacterial prophylaxis or the use of growth factors if our patients are in remission. Grade 3 neutropenia, as we pointed out, was very common, so around 50% with azocitadine and around 40% with decitabine. Grade 3 neutropenia, for those of you that aren't familiar, is an ANC of less than 1,000. So there are recommendations for interruption of therapy for cytopenias. So first we'll start out with what to do during cycle 1. So I'll focus only on the left part of this table here, and then we'll talk about the right side of the table after going through the patient case for cycle 1. So during cycle 1, in general, if you do experience cytopenias, you're going to transfuse blood products and administer prophylactic anti-infective agents if indicated, if that's your institutional practice. And treatment should not be interrupted in most cases during cycle 1 because you want to continue treatment if your patient is not in remission yet. And so we'll practice this with a patient case. So this is still Mrs. R's case. So she's cycle 1, day 28, and her bone marrow biopsy shows a complete remission. She did have grade 4 neutropenia for the past 8 days. So today is day 29. Your recommendation during rounds is as follows. 1, continue venetoclax. 2, hold venetoclax until count recovery and dose reduced to 50 milligrams daily. 3, hold venetoclax, consider GCSF, and resume venetoclax at the same dose in combination with azocitadine when your ANC has resolved to grade 1 or 2, or 4, none of the above. So the thing that I ask myself to be able to answer these questions is the patient in remission? If the answer is yes, then you're gonna hold therapy until counts recover. If this happens during your first cycle, for your next cycle, you're going to resume therapy at the same dose. Now, there are recommendations for cytopenia management after a patient's in remission. So grade 4 neutropenia is an ANC of less than 500, and grade 4 thrombocytopenia is a platelet count of less than 25,000, so keeping that in mind. So the recommendation is for your first occurrence of cytopenias after being in complete remission, if you have grade 4 cytopenias that last greater than 7 days, you want to delay treatment and monitor the blood counts. You can administer a GCSF for neutropenia if your patient is in remission. And then once your counts have recovered to grade 1 or 2, resume venetoclax at the same dose. Now, if you have a second occurrence of cytopenias after your patient's in complete remission, that's when you want to think about decreasing the duration of venetoclax for the next cycle. But again, I always ask myself to kind of work through these questions. 1, is the patient in remission? If the answer is yes, then you can hold therapy. And 2, what occurrence is this after the patient has been in remission? Because that's going to help you figure out if it's the first occurrence, you're going to resume therapy at the same dose, where if it's the second occurrence, you're going to think about decreasing the duration of venetoclax. So practicing this in a patient case, Cycle 2, day 18, the CBC results show that Mrs. R has experienced grade 4 neutropenia for the past 8 days. Your recommendation during rounds is as follows. 1, continue Venetoclax. 2, hold Venetoclax until counts recover and then dose reduce to 50 milligrams daily. Or 3, delay subsequent treatment cycle of Venetoclax and Azocitadine and monitor blood counts. Transfuse blood products, administer prophylactic antimicrobials, and consider GCSF. And resume Venetoclax at the same dose in combination with Azocitadine when ANC has resolved to grade 1 or 2, or 4, none of the above. So to answer this question, I asked myself, 1, is the patient in remission? So the answer is yes, she is, because remember her bone marrow biopsy after cycle 1 showed remission. So since she's in remission, we can hold therapy. And 2, I asked myself, what occurrence of cytopenias is this after being in remission? So this is the first episode of a grade 4 cytopenia after being in remission. So we're gonna hold therapy, and we can resume both Venetoclax and Azocitadine at full dose when counts have recovered. Okay. Oh. And then there was one more question here. So cycle 3, day 18, the CBC showed that Mrs. R has experienced grade 4 neutropenia for the past 8 days. Your recommendation during rounds is as follows. 1, continue Venetoclax. 2, hold Venetoclax until counts recover and dose reduce to 50 milligrams daily. 3, delay your treatment and monitor blood counts. Transfuse blood products, give prophylactic antimicrobials, and consider GCSF. And then once your counts have recovered to grade 1 or 2, resume Venetoclax at the same dose and duration reduced by 7 days for each subsequent cycle. So asking myself those questions, 1, is the patient in remission? Yes, she is, so we can hold therapy. And 2, what occurrence of grade 4 cytopenias is this after being in remission? So this is the second occurrence of grade 4 cytopenia after being in complete remission. So we are going to, number 3, decrease the duration of Venetoclax by 7 days for our subsequent cycles. So in this case, when we go to cycle 4, we're gonna decrease the Venetoclax duration to 21 days. Another note is Venetoclax is dose reduced in hepatic impairment. So looking at the LFTs when you're thinking about treatment. And in summary here, really exciting that we now have this treatment option for our patients that are elderly or have comorbidities that preclude them from being able to get intensive induction. But this is a regimen that does require extensive monitoring, and it is a regimen that pharmacists can play a big role in helping guide dosing recommendations. So remember, as far as dose modifications with drug interactions, posaconazole is in its own category from other strong CYP3A4 inhibitors. You're thinking about strong CYP3A4 inhibitors reducing dose by 75% and by 50% with moderate CYP3A4 inhibitors. And then when you do discontinue your interacting agent, you can increase Venetoclax back up to full dose after 2 to 3 days. And then when you're thinking about cytopenia management, some of the general rules to follow is asking yourself, is your patient in remission? If they are not in remission, you should be continuing therapy. If they are in remission, then you can hold therapy. And then asking yourself, what occurrence of grade 4 cytopenias is this after being in complete remission? So for your first occurrence, you're going to delay therapy and then continue at the same dose when counts recover. And for subsequent occurrences of cytopenias after being in complete remission, that's when you're going to delay therapy and continue and consider decreasing the duration of Venetoclax for subsequent cycles. So I know that was a lot of information, but I thank all of you today for listening to this presentation. And I look forward to seeing pharmacists really play a role in the care of these patients. Thank you.